And welcome back to another chapter of Advanced Pathophysiology. This time we're reading chapter 36. However, just small portions of it. We're not doing the complete entirety of the chapter. So, again, my pages may not correlate with yours, but we'll jump right into it. I believe I am stopping at 3727, which would lead us right about. No, just before the acute lung injury and acute respiratory distress. So, up until then, I will be reading. Other than that, we will jump right into the chapter. So, the alterations of lung function. Your pulmonary disease is often classified as acute or chronic, obstructive or restrictive, infectious or non-infectious. The symptoms of signs of lung disease, such as dyspnea and tachypnea, are common and associated not only with primary lung disorders, but also with diseases of organ systems, particularly the heart. So, what kind of clinical manifestations of pulmonary alterations will we see? Well, signs and symptoms of pulmonary disease. Pulmonary disease is associated with many signs and symptoms and their specific characteristics often help in identifying the underlying disorder, the most of which, or the most common of which, include dyspnea and a cough. However, others include abnormal sputum, hemoptysis, altered breathing patterns, hypo or hyperventilation, your cyanosis, clubbing of the digits, and chest pain. So we'll jump right into dyspnea. Dyspnea is the subjective experience of breathing discomfort and is the most common symptom of cardiac and respiratory disease. It also can occur with pain, trauma, anxiety, or psychogenic disorders. The experience derives from the interactions among multiple physiologic, psychologic, social, and environmental factors, and it may induce a secondary physiologic and behavioral response. The American Thoracic Society proposes that dyspnea evolves across three different constructs: a sensory intensity, affective distress, and the impact on daily activities. It is comprised of qualitatively distinct sensations that vary in intensity. Individuals with dyspnea may complain of breathlessness, air hunger, shortness of breath, increased work of breathing, chest tightness, and the preoccupation with breathing. The severity of the experience of dyspnea may not directly correlate with the severity of the underlying disease. Either diffuse or focal disturbances of ventilation, gas exchange, or ventilation-perfusion relationships can cause dyspnea, as can result increased work of breathing or disease that damages lung tissue in the lung parenchyma. Your neurophysiologic mechanisms for dyspnea involve an impaired sense of effort, where the perceived work of breathing is greater than the actual motor response generated. Stimulation of a variety of receptors can contribute to the sensation of experience of dyspnea, including lower airway mechanoreceptors, your upper airway receptors, and central and peripheral chemoreceptors that interact with the respiratory center and the sensory and motor cortex. The more severe signs of dyspnea include the flaring of the nostrils and the use of accessory muscles of the respirations. Your retractions or pulling back of the supracostal or intercostal spaces predominated in children. In dyspnea caused by parenchymal disease, such as pneumonia, retractions of tissue between the ribs, that subcostal or intercostal retraction, are observed more often than supracostal retractions, retractions of the tissues above the ribs. which predominate in the upper airway obstruction. Retractions of any type are more commonly seen usually in children than in adults, who are thin and have poor developed thoracic musculature. Dyspnea can be quantified by the use of the ordinal rating scale or visual analog scales. Dyspnea can occur transiently or can become chronic. Dyspnea first presents during exercise and is called dyspnea on exertion. Orthopnea is dyspnea that occurs during heart failure, when an individual is recumbent, which causes an abdominal contents to exert pressure on the diaphragm and decreases the efficiency of the respiratory muscles. Your paroxysmal nocturnal dyspnea occurs when individuals with pulmonary or cardiac disease awake at night, gasping for air and must sit up or stand to relieve the dyspnea. Your cough is a protective reflex that helps clear the airway by an explosive expiration. Inhaled particulates, accumulated mucus, inflammation, or the presence of a foreign body initiates the cough reflex by stimulating irritant receptors in the airway. There are few such receptors in the most distal bronchi and the alveoli. Thus, it is possible for significant amounts of secretions to accumulate in the distal respiratory tree without cough being initiated. Stimulation of the cough receptors is transmitted centrally through the vagus nerve. The cough reflex consists of inspiration of air, closure of the glottis and vocal cords, contraction of that expiratory muscle, and reopening of the glottis, causing a sudden, forceful expiration that removes the offending matter. The effectiveness of the cough depends on the depth of the inspiration and the degree to which the airways narrow, increasing the velocity of the expiratory gas flow. Somatosensory nerves innervating the chest wall, diaphragm, and abdominal musculature regulate cough patterning and sensitivity. Cough occurs frequently in healthy individuals, and those with an inability to cough effectively are at greater risk for pneumonia. Cough, the urge to cough sensation, and the cough motor response can be manipulated by the distraction and the cognitive states, such as an anxiety, reflecting a voluntary component of cough. Central modulation of the cough reflex can be influenced by opiates and serotonergic agents. An acute cough is a cough that resolves within 2 to 3 weeks of onset of illness or resolves with the treatment of an underlying condition. It is most commonly the result of an upper respiratory tract infection, allergic rhinitis, acute bronchitis, pneumonia, congestive heart failure, a pulmonary emboli, or aspiration. Chronic cough is defined as a cough that has persisted for more than 3 weeks, although some researchers have suggested that 7 or 8 weeks is a more appropriate time frame. Because acute cough and bronchial hyperreactivity can be prolonged in some cases of viral infections. In a person who does not smoke, chronic cough is commonly caused by a postnasal drainage syndrome, non-asthmatic eosinophilic bronchitis, asthma, GERD, or a heightened cough reflex sensitivity. In those individuals who do smoke, however, chronic bronchitis is the most common cause of chronic cough, although lung cancer must always be considered. Individuals taking an angiotensin-converting enzyme inhibitor for their hypertension may develop a chronic cough that resolves when you discontinue those drugs. Your abnormal sputum. Changes in the amount, consistency, color, and odor of sputum provide information about the progression of a disease and the effectiveness of its therapy. The gross and microscopic appearance of sputum enable the clinician to identify cellular debris or microorganisms that aid in identifying, diagnosing, and the choice of therapy. Hemoptysis is the expectoration of blood or bloody secretions from the lower respiratory tract. This is sometimes confused with hematemesis, which is vomiting of blood. Blood that is expectorated is usually bright red, has an alkaline pH, and is mixed with a frothy sputum. Blood that is vomited is dark, has an acidic pH, and is mixed with food particles. Hemoptysis usually indicates infection or inflammation that damages the bronchi via bronchitis or bronchiectasis, or the lung parenchyma via pneumonia, tuberculosis, or lung abscess. Other causes include cancer and pulmonary infarct. The amount and duration of bleeding provide important clues about its source. A bronchoscopy combined with chest imaging is used to confirm the site of bleeding. Your abnormal breathing patterns. Normal breathing, eupnea, is rhythmic and effortless. The ventilatory rate is 8 to 16 breaths per minute, and the tidal volume ranges from 400 to 800 ml. A short expiratory pause occurs with each breath, and the individual takes an occasional deeper breath or sigh. Sigh breaths, which help maintain normal lung function, are usually 1.5 to 2 times the normal tidal volume and occur approximately 10 to 12 times per hour. The rate, depth, regularity, and effort of breathing undergo characteristic alterations in response to physiologic and pathophysiologic conditions. Patterns of breathing automatically adjust to minimize the work of respiratory muscles. Strenuous exercise or metabolic acidosis induces Kussmaul respirations, your hyperapnea. Kussmaul respirations are characterized by a slightly increased ventilatory rate, very large tidal volume, and no expiratory pause. Labored breathing occurs whenever there is an increased work of breathing, especially if the airway are obstructed, as in chronic obstructive pulmonary disease or your COPD. If the large airway are obstructed, a slowed ventilatory rate, increased effort, prolonged inspiration or expiration, and stridor or audible wheezing are typical. In small airway obstruction, like that seen in asthma or chronic obstructive pulmonary disease, a rapid ventilatory rate, small tidal volume, increased effort, prolonged expiration, and wheezing are often present. Restrictive breathing is commonly caused by disorders such as pulmonary fibrosis that stiffen the lungs or chest wall and decrease its compliance, resulting in small tidal volume and rapid ventricular rate. Shock and severe cerebral hypoxia contribute to gasping respirations that consist of irregular, quick inspirations with expiratory pause. Anxiety can cause sighing respirations that consist of irregular breathing characterized by frequent, deep sighing inspirations. Your Cheney-Stokes respirations are characterized by alternating periods of deep and shallow breathing. Apnea, lasting 15 to 60 seconds, is followed by ventilation that increases in volume until a peak is reached, after which ventilation decreases again to apnea. Cheyne-Stokes respiration result from a condition that slows the blood flow to the brainstem, which in turn slows impulses sending information to the respiratory center of the brainstem. Neurologic impairment above the brainstem is also a contributing factor. Your hypo and hyperventilation. Hypoventilation is inadequate alveolar ventilation in relation to metabolic demands. Hypoventilation occurs when the minute volume is reduced. It is caused by alterations in pulmonary mechanics or in the neurologic control of breathing. When alveolar ventilation is normal, your carbon dioxide is removed from the lungs at the same rate at which it is produced by a cellular metabolism, and arterial CO2 pressure remains at normal levels, your 40 milligrams of mercury. With hypoventilation, however, your CO2 remains or lags behind CO2 production and PaCO2 increases, causing hypercapnia. So your PaCO2 pressure is greater than 44 milligrams of mercury. This results in an increase in hydrogen ion concentration in the blood and is termed respiratory acidosis, which can affect the function of many tissues throughout the body. Hypoventilation is often overlooked until it is severe because breathing pattern and ventilatory rate may appear normal and changes in tidal volume are difficult to see clinically. Blood gas analysis or capnography will reveal, however, hypoventilation and hypercapnia. Pronounced hypoventilation can cause somnolence and disorientation and secondary hypoxemia because of the accumulation of alveolar CO2, which displaces the oxygen. During hyperventilation is when alveolar ventilation that exceeds metabolic demand. The lungs remove CO2 at a much higher rate than it is even being produced by a metabolic cellular level, resulting in a decrease in a PaCO2 or hypocapnia. So you'll see an ABG of PaCO2 less than 36 milligrams of mercury. Your hypocapnia results in respiratory alkalosis that also can interfere with tissue function. Like hypoventilation, hyperventilation can be verified via an ABG and capnography. Hyperventilation commonly occurs with the severe anxiety, an acute head injury, and conditions that cause hypoxemia. Cyanosis. Cyanosis is a bluish discoloration of the skin and mucous membranes, caused by increasing amounts of desaturated or reduced hemoglobin in the blood. It generally develops when 5 grams of hemoglobin is desaturated, regardless of hemoglobin concentration. That peripheral cyanosis, your slow blood circulation in the fingers and toes, is most often caused by poor circulation resulting from intense peripheral vasoconstriction, like that seen in Raynaud's disease, cold environments, or severe stress. Peripheral cyanosis is best seen in the nail beds. Your central cyanosis is caused by the decreased arterial oxygenation from pulmonary disease or pulmonary or cardiac right to left shunts. Central cyanosis is best seen in buccal mucous membranes and lips. Lack of cyanosis does not necessarily indicate that oxygenation is normal. In adults, cyanosis is not evident until severe hypoxemia is present, and therefore is an insensitive indication of respiratory failure. Severe anemia and carbon monoxide poisoning can result in inadequate oxygenation of tissues without causing cyanosis. Individuals with polycythemia, an abnormal increase in number of red blood cells, however, may have cyanosis when tissue oxygenation is adequate. Therefore, the significance of cyanosis as a clinical finding must be interpreted in relation to the underlying pathophysiology. If cyanosis is observed, a PaO2 level should be measured. Clubbing is a selective bulbous enlargement of the end of a digit in your fingers and toes. Its severity can be graded from 1 to 5, based on the extent of the nail bed hypertrophy and the number of changes in the nails themselves. It is usually painless and develops gradually over weeks. Clubbing is commonly associated with diseases that disrupt the normal pulmonary circulation and cause chronic hypoxemia, such as bronchiectasis, cystic fibrosis, pulmonary fibrosis, lung abscesses, and congenital heart disease. It is rarely reversible with treatment of the underlying pulmonary condition. And here we're taking a look at a couple pictures of early clubbing, moderate clubbing, and severe clubbing. Although the pathogenesis of clubbing is unknown, the megakaryocyte hypothesis proposes that megakaryocytes and platelet clumps escape filtration in the pulmonary bed and enter the systemic circulation. Platelets may then release platelet-driven growth factor at the nail bed, causing a periosteal change. Your secondary hypertrophic Osteoarthropathy can sometimes be seen in individuals with lung cancer, even without hypoxemia, because of the effect of the inflammatory cytokines and growth factor. Pain. Pain caused by pulmonary disorders originates in the pleura airway, or chest wall. Pleural pain is the most common pain caused by pulmonary disease and is usually sharp or stabbing in character. Infection and inflammation of the parietal pleura, pleuritis, or pleurisy cause pain when the pleurae stretch during inspiration. The pain is usually localized in a portion of the chest wall, where a unique breath sound called a pleural friction rub may be heard over the painful area. Laughing or coughing makes pleural pain worse. Infection and inflammation either of the trachea or the or of the trachea and the bronchi, so a tracheitis or tracheobronchitis, can cause central chest pain that is pronounced after coughing. Central chest pain can be difficult to differentiate from cardiac pain. Your high blood pressure in the pulmonary circulation can cause pain during exercise that is often mistaken for cardiac pain. Your pleural pain is also common with pulmonary infarction, caused by pulmonary embolism and emanates from the area around the infarction. Pain in the chest wall is muscle pain or rib pain. The common cause of chest wall pain are rib fractures and excessive coughing, which makes the muscles sore. Inflammation of costochondral junction or costochondritis also cause chest wall pain. Chest wall pain can often be reproduced by pressing on the sternum or ribs. This falls us into the conditions that can cause pulmonary disease or injury, starting off with hypercapnia. Hypercapnia, or an increase in your CO2 concentration in the arterial blood, is caused by the hypoventilation of the alveoli. CO2 is easily diffused from the blood into the alveolar space. Thus, minute volume determines not only alveolar ventilation but also the PaCO2. Hypoventilation is often overlooked because the breathing pattern and ventilatory rate may appear normal. It is important to obtain blood gas analysis to determine the severity of the hypercapnia and resultant respiratory acidosis. There are many causes of hypercapnia. Most are a result of a decreased drive to breathe or an inadequate ability to respond to the ventilatory stimulation, such as depression of the respiratory center via drugs, diseases of the medulla, including infections of the central nervous system or trauma, abnormal or abnormalities of the spinal conducting pathways, as in a spinal cord disruption or poliomyelitis, diseases of the neuromuscular junction or of the respiratory muscles themselves, as seen in myasthenia gravis or muscular dystrophy, abnormalities of the thoracic cage, or in chest injury or congenital deformity, obstruction of the large airways, like tumors or in sleep apnea, and an increased work of breathing or increased physiologic dead space, like an emphysema. Hypercapnia and the associated respiratory acidosis can result in several important clinical manifestations. Of greatest concern are electrolyte abnormalities that occur in response to that low pH that may cause dysrhythmias. Individuals also may have somnolence and even be in a coma because of the changes in that intracranial pressure that's associated with high levels of arterial carbon dioxide, which causes cerebral vasodilation. Alveolar hypoventilation with increased alveolar carbon dioxide concentration limits the amount of alveolar oxygen available for diffusion into the blood, leading to secondary hypoxemia. Hypoxemia, or reduced oxygenation of arterial blood, is caused by respiratory alterations, whereas hypoxemia or ischemia, or reduced oxygenation of cells and tissues, may be caused by alterations of other systems as well. Cyanosis, hypoxemia, hypoxia can exist independently of each other, but they are interrelated. For example, although hypoxemia can lead to tissue hypoxia can result from other abnormalities, such as low cardiac output or cyanide poisoning. Hypoxemia results from problems with one or more of the major mechanisms of oxygenation. So if our oxygen delivery to the alveoli, the oxygen content of that inspired FiO2, the ventilation of the alveoli, or 2, diffusion of oxygen from the alveoli into the blood. The balance between that alveolar ventilation and perfusion, that VQ mismatch. Diffusion of oxygen across the alveolar capillary membrane. Or 3, perfusion of the pulmonary capillaries. And here are some, lists of common problems that cause these. So, if, for instance, the mechanism is a decrease in inspired oxygen, it could be due to the fact that you're sitting at high altitude, standing on Mount Everest without an oxygen tank, low oxygen content of gas mixture, or enclosed breathing spaces, such as suffocation. Your hypoventilation of the alveoli, lack of neurologic stimulation of the respiratory center, so your oversedation, drug overdose, your neurologic damage. There's also defects in the chest wall mechanics, your neuromuscular disease, trauma, chest deformity, or air trapping, your large airway obstruction, your laryngospasm, foreign body aspiration, a neoplasm, and lastly, that increased work of breathing from emphysema or severe asthma, all can cause hypoventilation of the alveoli. Then you could have that ventilation perfusion mismatch that can occur when you have asthma, chronic bronchitis, pneumonia, acute respiratory distress syndrome or ARDS, atelectasis, and pulmonary emboli, those PEs. Your alveolar capillary diffusion abnormalities, however, can occur from edema, fibrosis, and emphysema. And lastly, the decreased pulmonary capillary perfusion can occur due to an intracardiac defect or intrapulmonary arteriovenous malformation. So, all of these, the partial pressure of that oxygen in the alveoli is called PaO2 and is dependent on 2 factors. The first factor is the amount of oxygen in inspired air and is expressed as the percentage of a fraction of the air that is composed of oxygen, called the FiO2. The FiO2 of the air at sea level is approximately 21%. Anything that decreases the FiO2, such as high altitude, will decrease the PaO2. The second factor is the amount of alveolar minute ventilation, that tidal volume and respiratory times the respiratory rate. Hypoventilation results in an increase in PaCO2 and a decrease in PaO2, such that there is less oxygen available in the alveoli for diffusion into the blood. This type of hypoxemia can be completely corrected if alveolar ventilation is improved by increasing the rate and depth of breathing. Examples of these conditions include hypoventilation causes hypoxemia, such as unconsciousness, neurologic, muscular, or bone disease that restrict chest expansion, like COPD. A diffusion of oxygen from the alveoli into the blood is also dependent on 2 factors. The first is the balance between the amount of air getting into the alveoli, the volume, and the amount of blood perfusing the capillaries around the alveoli, the Q. An abnormal ventilation perfusion ratio, that volume divided by perfusion, is the most common cause of hypoxemia. In the healthy lung, alveolar capillary lung units receive almost equal amounts of ventilation and perfusion. The normal VQ is 0.8 to 0.9 because perfusion is somewhat greater than ventilation in the lung basis and because some blood is normally shunted to the bronchial circulation. VQ mismatch refers to an abnormal distribution of the ventilation and perfusion. Hypoxemia can be caused by inadequate ventilation as well, perfused areas of the lung, low VQ, mismatching of this type, called shunting, occurs in atelectasis, in asthma as a result of a bronchoconstriction, and in pulmonary edema and pneumonia, where alveoli are filled with fluid. When blood passes through portions of the pulmonary capillary bed that receive no ventilation, right to left shunt occurs, resulting in decreased systemic PaO2 and hypoxemia. Hypoxemia also can be caused by poor perfusion of well-ventilated portions of the lung, a high VQ, resulting in wasted ventilation. The most common cause of a high VQ is a pulmonary embolus that impairs blood flow to a segment of the lung. An area where alveoli are ventilated but not perfused is termed alveolar dead space. A second factor affecting diffusion of oxygen from the alveoli into the blood is the alveolar capillary barrier. Diffusion of oxygen through the alveolar capillary membrane is impaired if the alveolar capillary membrane is thickened or the surface area available for diffusion is decreased. Abnormal thickness, as occurs with edema, your tissue swelling, and fibrosis, that formation of fibrous lesions, increases the time required for diffusion across the alveolar capillary membrane. If diffusion is slowed enough, the oxygen in the alveolar gas and capillary blood does not have the time to equilibrate during the fraction of a second that blood remains in the capillaries. Destruction of the alveoli, such as that which occurs in emphysema, decreases alveolar capillary membrane surface area available for that diffusion. Hypercapnia is rare, produced by impaired diffusion because carbon dioxide diffuses easily from capillary to alveolus, even when oxygen diffusion is significantly impaired. Hypoxia also can result from blood flow bypassing the lungs. This can occur because of the intracardiac defects that cause right to left shunting or because of intrapulmonary arteriovenous malformations. Administration of oxygen in these cases does not improve that hypoxemia. Hypoxemia is most often associated with a compensatory hyperventilation and resultant respiratory alkalosis. However, in individuals with associated ventilatory difficulties, hypoxemia may be complicated by hypercapnia and respiratory acidosis. Hypoxemia results in widespread tissue dysfunction and, when severe, can lead to organ infarction. In addition, hypoxic pulmonary vasoconstriction can contribute to the increased pressure in the pulmonary artery and lead to right-sided heart failure, or cor pulmonale. Your clinical manifestations of acute hypoxemia may include cyanosis, confusion, tachycardia, edema, and a decrease in renal output. So, acute respiratory failure. Respiratory or lung failure is defined as inadequate gas exchange. That is, hypoxemia in which APO2 is less than 50 milligrams of mercury, or hypercapnia, in which a PaCO2 is greater than 50 milligrams of mercury and our overall pH is less than 7.25. Respiratory failure can result from direct injury to the lungs, airways, or chest wall, or can occur indirectly as a result of disease or injury involving another body system, such as the brain, spinal cord, liver, or heart. It can occur in individuals who have otherwise normal respiratory system, or in those with underlying chronic pulmonary disease. Most pulmonary disease can cause episodes of acute respiratory failure. If the respiratory failure is primarily hypercapnic, it is a result of inadequate alveolar ventilation, and the individual must receive ventilatory support, such as with bag valve mask, non-invasive positive pressure ventilation, or intubation. and placement on mechanical ventilation. If the respiratory failure is primarily hypoxemic, it is the result of inadequate exchange of oxygen between the alveoli and the capillaries, and the individual must receive supplemental oxygen therapy. Many individuals have a combined hypercapnic and hypoxemic respiratory failure and require both kinds of support. Respiratory failure is an important potential complication of any major surgical procedure, especially those that involve the central nervous system, your thorax, or upper abdomen. A person who smokes are at risk, particularly if they have pre-existing lung disease, limited cardiac reserve, chronic renal failure, chronic hepatic disease, or underlying disease, and infection all increase the tendency to develop postoperative respiratory failure. The most common postoperative pulmonary problems are atelectasis, pneumonia, pulmonary edema, and pulmonary emboli. Your prevention of postoperative respiratory failure includes frequent turning and position changes, deep breathing exercises, incentive spirometry, avoidance of oversedation, and early ambulation to prevent atelectasis and accumulation of secretions. Incentive spirometry gives individuals immediate feedback about tidal volume, which encourages them to breathe deeply. Supplemental oxygen is given for hypoxemia, and antibiotics are given as appropriate to treat infections. If respiratory failure develops, the individual may require conventional mechanical ventilation, a high-frequency ventilation, or extracorporeal membrane oxygenation. Disorders of the chest wall and pleura. So your disorders of the chest wall include chest wall restriction. If the chest wall is deformed, traumatized, immobilized, or made heavy by fat, the work of breathing is increased and ventilation may compromise because of the decrease in tidal volume. The degree of ventilatory impairment depends on the severity of the chest wall abnormality. Grossly obese individuals are often dyspneic on exertion or when recumbent. Individuals with severe kyphoscoliosis often present with dyspnea on exertion that can progress to respiratory failure. Obesity and kyphoscoliosis are risk factors for respiratory failure or infection in individuals admitted to the hospital for other problems, particularly those who require surgery. Other musculoskeletal abnormalities can impair ventilation, are ankylosing spondylitis and pectus excavatum. The deformity are characterized by depression of the sternum. Impairment of the respiratory muscle function caused by neuromuscular disease, such as a poliomyelitis, muscular dystrophy, myasthenia gravis, or Guillain-Barré syndrome, also can restrict the chest wall or impair pulmonary function. Muscle weakness can result in hypoventilation and hypercapnia, inability to remove secretions, and hypoxemia. Pain from the chest wall injury, surgery, and disease can cause significant hypoventilation, not only because of the pain, but also because of the structural and mechanical change that impair the ability of the chest to expand normally. Flail chest results from the fracture of several consecutive ribs in more than one place, or the fracture of the sternum and several consecutive ribs. These multiple fractures result in instability of a portion of the chest wall, causing paradoxical movement of the chest with breathing. During the negative intrathoracic pressure of inspiration, the unstable portion of the chest wall moves inward, and during expiration, it moves outward, impairing movement of that gas in and out of the lungs. Flail chest is usually associated with significant underlying lung contusion. The clinical manifestation of flail chest are pain, dyspnea, unequal chest expansion, and hypoventilation. Treatment is internal fixation by controlled mechanical ventilation until the chest wall is stabilized. So here we're taking a look at flail chest, normal respiration A, then you have that inspiration, expiration, your paradoxical motion, your inspiration, the area of the lung underlying unstable chest wall sucks in on the inspiration. And then D, the expiration. The unstable wall balloons out. So take note of the movement of the mediastinum towards opposite lung during inspiration. The chest wall restriction results in decreased tidal volume. An increase in respiratory rate can temporarily compensate and restore minute ventilation, but many individuals will eventually progress to hypercapnic respiratory failure. Diagnosis of chest restriction is made by pulmonary function testing, arterial blood gas measurements, and radiography. Treatment is aimed at any reversible underlying cause, but is otherwise supportive. In severe cases, mechanical ventilation is indicated. So your pleural abnormalities, your pneumothorax. Pneumothorax is the presence of air or gas in the pleural space caused by a rupture in the visceral pleura that surrounds the lungs, or the parietal pleura and the chest wall. As air is drawn into the pleural space during inspiration, it separates the visceral and parietal pleura and destroys the negative pressure of the pleural space. This disrupts the state of equilibrium that normally exists between the elastic recoil forces of the lung and the chest wall. No longer held in check by that recoil force of the chest wall, the lung fulfills its tendency to recoil by collapsing towards the hilum. So there is a primary or spontaneous pneumothorax that occurs unexpectedly, it occurs unexpectedly, usually in the healthy individual, men between the age 20 to 40, and is caused by a spontaneous rupture of blebs. Blebs are blister-like formations on the visceral pleura. Your biggest risk factor is smoking. A bleb rupture can occur during sleep, rest, or exercise. The ruptured bleb or blebs are usually located in the apex of the lungs, the very top, and cause the bleb formation. The cause of bleb formation is not known, although more than 80% of these individuals have been found to have an emphysema-like change in the lungs, even if they have no history of smoking or no known genetic disorder. About 10% of affected individuals have a significant family history of primary pneumothorax that has been linked to autosomal dominant mutations in the folliculin gene, which influence cell-to-cell adhesion and cell growth and cause cystic lung disease and kidney tumors. It's the Bird-Hogg-Doob syndrome. Ruptured bleb damage the visceral pleura and create a conduit for air to travel from the lower airways into the pleural space, a bronchopleural fistula. And then you have your secondary pneumothorax, and that is caused by trauma, such as a rib fracture, a stab or bullet wound, or a surgical procedure that tears the pleura. A rupture of a bleb or bulla, which is a larger vesicle, as occurs in COPD, or mechanical ventilation, particularly if it includes positive and expiratory pressure, that PEEP. Iatrogenic pneumothorax is most commonly caused by transthoracic needle aspiration. Primary and secondary pneumothorax can present as either open or tension. In an open pneumothorax, communicating pneumothorax, air pressure in the pleural space equals barometric pressure, because air that is drawn into the pleural space during inspiration through the damaged chest wall and parietal pleura, or through the lungs and the damaged visceral pleura, is forced back out during expiration. In tension pneumothorax, however, the site of pleural rupture acts as a one-way valve, permitting air to enter on inspiration, but preventing it from escaping by closing during expiration. As more and more air enters into the pleural space, the air pressure in the pneumothorax begins to exceed barometric pressure. Air pressure in the pleural space pushes against the already recoiled lung, causing compression atelectasis, and against the mediastinum, compressing and displacing the heart, great vessels, and trachea. The pathophysiologic effect of a tension pneumothorax is life-threatening. So here we're taking a look at a tension pneumothorax. Air in the pleural space causes the lung to collapse around the hilum and may shift the trachea and mediastinal content, the heart and great vessels, towards the other lung. So it's pushing onto that lung. Clinical manifestations of primary or secondary pneumothorax begin with sudden pleural pain, tachypnea, and dyspnea. Depending on the size of the pneumothorax, physical examination may reveal absent or decreased breath sounds and hyperresonance to percussion on the affected side. Tension pneumothorax may be complicated by severe hypoxemia, tracheal deviation away from the affected lung, and hypotension. Deterioration occurs rapidly and immediate treatment is required. A diagnosis of a pneumothorax is made with chest radiograph, ultrasound, and CT. Pneumothorax is treated by aspiration, usually with insertion of a chest tube that is attached to a water-sealed drainage system with suction. After the pneumothorax is evacuated and the pleural rupture is healed, the chest tube can be removed. For individuals with persistent air leaks, other interventions may be needed, including a thoracoscopic surgical technique or pleurodesis. A Heimlich valve provides an option for home care in persistent spontaneous pneumothorax. It's strongly suggested to stop smoking. Your pleural effusion. Pleural effusion is the presence of fluid in the pleural space. The source of the fluid is usually from blood vessels or the lymphatic vessels lying beneath the pleura, but occasionally an abscess or other lesion may drain into the pleural space. Pleural effusion that enter the pleural space from intact blood vessels can be transudative, watery, or exudative. That's full of proteinaceous fluid accumulating at a rate faster than it can be removed by the lymphatic system. Other types of pleural effusions are characterized by the presence of pus, your empyema, blood, hemothorax, or chyle, your lymphatic fluid. Mechanisms of pleural effusion are summarized here at this table. So your transudative is a watery, exudative, fluid-enriched proteins, your leukocytes, your empyema, your pus, is detritus of infectious microorganisms, your hemothorax or blood is your hemorrhage into the pleural space, and your chylothorax is chyle, that milky fluid containing lymph and fat droplets. Your transudative pleural cells, or transudative pleural effusions, are often clear or slightly discolored and contain few cells and little protein. Examples are congestive heart failure, in which venous or left arterial pressure is increased, and liver or kidney disorders that cause hypoproteinemia. Hypoproteinemia decreases capillary oncotic pressure, which promotes diffusion of water out of the capillaries. Exudative effusion occurs in response to inflammation, infection, or a malignancy, and involves inflammatory processes that increase capillary permeability. When stimulated by biochemical mediators of inflammation, junctions in the capillary endothelium separate slightly, which enables leukocytes and plasma proteins to migrate out of the affected tissue. Thus, high concentrations of white blood cells and plasma proteins are evident in exudative effusions. Exudative effusions that occur in association with pneumonia are called a parapneumotic effusion. These often resolve with treatment of the underlying infection, but can progress to empyema. Small collections of fluid may not affect lung function and remain undetected. Most will be removed by the lymphatic system once the underlying condition is resolved. Dyspnea, compression atelectasis with impaired ventilation, and pleural pain are common in larger effusions. Mediastinal shift and cardiovascular manifestations occur in a large, rapidly developing effusion. Physical examination reveals decreased breath sounds and dullness to percussion on the affected side. A pleural friction rub can be heard over the areas of inflamed pleura. Your diagnosis is confirmed by chest imaging and a thoracentesis, which can determine the type of effusion and provide symptomatic relief. If the effusion is large, drainage usually requires a placement of a chest tube, and surgical intervention may be needed to prevent recurrence of the effusion. Empyema. Empyema is the infected pleural effusion, and that is the presence of pus in the pleural space, and develops when the pulmonary lymphatics become blocked, leading to an outpouring of contaminated lymphatic fluid into the pleural space. Empyema progresses through three stages: the exudative stage, the fibrinopurulent stage, and the organizing stage with pleural peel formation. Empyema occurs most commonly in older adults and in children, and usually develops as a complication of a pneumonia, surgery, trauma, or a type of bronchial obstruction from a tumor. Commonly documented infectious microorganisms include Staphylococcus aureus, E. coli, anaerobic bacteria, and Klebsiella pneumoniae. Individuals with empyema present clinically with cyanosis, fever, tachycardia, cough, and pleural pain. Breath sounds and decreased directly over the empyema. Diagnosis is made by chest radiograph, thoracentesis, and a sputum culture. Treatment for empyema include the administration of appropriate antimicrobials and drainage of the pleural space with a chest tube. In severe cases, ultrasound-guided pleural drainage, installation of fibrinolytic agents, and/or the injection of a deoxyribonuclease into the pleural space may be needed to achieve adequate drainage. Surgical debridement may also be required. So now we're jumping into pulmonary disorders. Restrictive lung disorders. Your restrictive lung disorders are characterized by a decreased compliance of the lung tissue. This means it takes more effort to expand the lungs during inspiration, which increases the work of breathing. Individuals with lung restrictive or lung restriction have dyspnea, an increased respiratory rate, and a decreased tidal volume. Pulmonary function testing reveals a decrease in that FVC. Restrictive lung diseases can cause a VQ mismatch and affect the alveolar capillary membrane, which reduces the diffusion of oxygen from the alveoli into the blood and result in hypoxemia. Some of the most common restrictive lung diseases in adults are aspiration, atelectasis, bronchiectasis, bronchiolitis, pulmonary fibrosis, inhalation disorders, pneumoconiosis, allergic alveolitis, pulmonary edema, and acute respiratory distress syndrome. These disorders are characterized by the activation of macrophages, polymorphonucleocytes, and lymphocytes, with release of numerous inflammatory and immune cytokines. So aspiration is the passage of fluid and solid particles into the lungs. It tends to occur in individuals whose normal swallowing mechanism and cough reflex are impaired by a decreased level of consciousness or a central nervous system abnormality. Predisposing factors include an altered level of consciousness caused by substance abuse, sedation, or anesthesia, seizure disorders, neuromuscular disorders that cause dysphagia, esophageal disorders such as achalasia and esophageal stricture, and feeding through a nasogastric tube. Intubation of the trachea also is associated with aspiration. The right lung, particularly the right lower lobe, is more susceptible to aspiration than the left lung because of its branching angle of the right mainstem bronchus is straighter than the branching angle of the left mainstem bronchus. Aspiration of large food particles has serious consequences. Solid food particles can obstruct the bronchus, resulting in bronchial inflammation and collapse of airway distal to the obstruction. If the aspirated solid is not identified and removed by bronchoscopy, a chronic local inflammation develops that may lead to a recurrent infection and bronchiectasis. Aspiration of oral and pharyngeal secretions can lead to aspiration pneumonia. Intubation of the trachea also can cause aspiration of bacterial pneumonia. Aspiration of acidic gastric fluid with a pH of less than 2.5 may cause severe pneumonitis. Bronchial damage includes inflammation, loss of ciliary function, and bronchospasm. In the alveoli, acidic fluid damages the alveolo-capillary membrane. This allows plasma and blood cells to move from capillaries into the alveoli, resulting in hemorrhagic pneumonitis. The lung becomes stiff and non-compliant as surfactant production is disrupted, leading to further edema and collapse. Infection is a common complication. Hypoventilation may develop as the process progresses, and systemic complications such as hypotension may occur. Clinical manifestations of aspiration include the sudden onset of choking and intractable cough with or without vomiting, fever, dyspnea, and wheezing. Some individuals have no symptoms acutely. Instead, they have recurrent lung infections, chronic cough, or persistent wheezing over months and even years. Preventative measures for individuals at risk are more effective than treatment of known aspiration. The most important preventative measure includes the avoidance of fully recumbent positioning and excessive sedation, surveillance of eternal feeding, and use of promotility agents. Individuals being administered general anesthetics should not receive food or fluid for several hours before or after surgery. Antacids are sometimes given to individuals at risk for aspiration to keep the gastric pH greater than 2.5. Nasogastric tubes, which often are used to remove stomach content and reduce the risk for aspiration, also can cause aspiration if fluid and particulate matter is regurgitated as the tube is being placed. So treatment of aspiration, pneumonia, and pneumonitis includes supplemental oxygen and may require mechanical ventilation. Fluid intake may be restricted to decrease blood volume and minimize pulmonary edema. Corticosteroids may be administered during the first 72 hours of aspiration. Bacterial pneumonia that develops as a complication of aspiration pneumonitis must be treated with broad-spectrum antibiotics. Atelectasis. Atelectasis is the collapse of lung tissue. There are three types of atelectasis: compression, absorption, or a surfactant impairment. Your compression atelectasis is caused by the external pressure exerted on the lung tissue, such as occurs with tumors or fluid or air in the pleural space. Atelectasis at the base of the lungs can be caused by the abdominal distension pressing on a portion of the lung, causing the alveoli to collapse. Absorption atelectasis results from the gradual absorption of air from obstructed or hypoventilated alveoli or from inhalation of concentrated oxygen or anesthetic agents. Surfactant impairment results from a decreased production or inactivation of surfactant, which is necessary to reduce surface tension in the alveoli and thus prevent lung collapse during expiration. Surfactant impairment can occur because of premature birth, acute respiratory distress syndrome, anesthesia, or mechanical ventilation. Atelectasis tends to occur after surgery, especially in those who have been administered general anesthetics. Post-operative individuals are often in pain, breathe shallowly, are reluctant to change position, and produce viscous secretions that tend to pool in dependent portions of the lung, particularly those who have surgical procedures involving the thorax or upper abdomen. Atelectasis increases pulmonary shunt decreases compliance, and may lead to a perioperative hypoxemia. Clinical manifestations of atelectasis are similar to those of pulmonary infection, dyspnea, cough, fever, and leukocytosis. Your prevention and treatment of postoperative atelectasis usually include deep breathing exercises, frequent position changes, early ambulation, and pain management. Deep breathing is beneficial because it promotes the ciliary clearance of secretions, stabilizes the alveoli by redistributing surfactant, and permits collateral ventilation of the alveoli through the pores of Kahn in the alveolar septa. The pores of the Kahn, which open only during deep breathing, allow air to pass from well-ventilated alveoli to obstructed alveoli, minimizing their tendency to collapse and facilitating expectoration of the bronchial obstruction. Here you're looking at the pores of Kahn. The absorption atelectasis caused by lack of collateral ventilation through the pores of Kahn, and then B, the restoration of collateral ventilation during deep breathing. Bronchiectasis. Bronchiectasis is persistent abnormal dilution or dilation of the bronchi. This disorder may result from a genetic predisposition or be caused by a defect in host defense. It usually occurs in conjunction with other respiratory conditions that are associated with chronic bronchial inflammation, such as obstruction of an airway with a mucus plug, atelectasis, aspiration of a foreign body, infection, cystic fibrosis, tuberculosis, congenital weakness of the bronchial wall, or immunocompromised status. Bronchiectasis is also associated with a number of systemic disorders such as a rheumatologic disease, inflammatory bowel disease, and immunodeficiency syndromes. Acquired immunodeficiency syndrome as AIDS, there may be no known cause whatsoever. So recurrent infection and chronic inflammation of the bronchi lead to the destruction of elastic and muscular components of their walls. Bronchial lumen obstruction, traction from adjacent fibrosis, and a permanent dilation. Bronchial dilation may be cylindrical, with symmetrically dilated airways, as can be seen after pneumonia and is reversible. Saccular bronchiectasis, in which the bronchi become large and balloon-like, or varicose, in which the constrictions and dilations deform the bronchi, creating a bulbous appearance. In both varicose and saccular bronchiectasis, the smaller bronchial divisions are plugged with secretions or obliterated with fibrosis. Large anastomosis develop between the bronchial and pulmonary blood vessels, increasing blood flow through the bronchial circulation. These anastomoses are thought to cause the hemoptysis experienced by individuals with bronchiectasis. Airway damage leads to the bronchospasm and colonization by bacteria that promote further lung damage, inhibit ciliary function, and produce copious amounts of purulent mucus. Ventilation perfusion abnormalities develop and result in hypoxemia. In severe cases, your minute ventilation is also compromised, and your PaCO2 level may become elevated, which means they are not breathing quickly. So here we're taking a look at bronchiectasis, a type of bronchiectasis. The left posterior oblique projection of the left bronchogram showing a cylindrical bronchiectasis affecting the entire lower lobe except for the superior segment. Few side branches fill, the basal airway are crowded together, indicating volume loss of the lower lobe, a common feature in bronchiectasis. And that last picture at the bottom is a cylindrical bronchiectasis, the dilated bronchi. And bronchioles can be dissected almost to the pleural surface. The primary symptom of bronchiectasis is chronic productive cough lasting for months or even years. The disease is commonly associated with recurrent lower respiratory tract infections and expectoration of voluminous amounts of foul-smelling purulent sputum. It's measured in cups. If the individual is not receiving antibiotics, the sputum has a foul odor. Clubbing of the fingers from chronic hypoxemia is common. Hemoptysis can occur from mucosal inflammation and necrosis, and in some instances can be massive. Your dyspnea, your pleuritic chest pain, and fatigue is common. Pulmonary function studies show a decrease in FVC and expiratory flow rates. Hypoxemia eventually leads to cor pulmonale. Diagnosis is usually confirmed by the use of a high-resolution CAT scan. Bronchiectasis is treated with antibiotics, bronchodilators, anti-inflammatory drugs, chest physiotherapy, and supplemental oxygen. In selected individuals with localized areas of involvement, surgery may be indicated to remove the affected portion of the lung. A lung transplant is an option in advanced disease. That brings us to bronchiolitis. Bronchiolitis is diffuse inflammation of the small airways, or bronchioles. It is the most common seen in children. In adults, it usually occurs with chronic bronchitis, but can occur in otherwise healthy individuals in association with an upper or lower airway viral infection, that RSV, or with the inhalation of toxic gases. But also, the etiology may be unknown. Atelectasis, or emphysematous destruction of the alveoli, may develop distal to the inflammatory lesion. Bronchiolitis is usually diffuse. The resulting decrease in ventilation-perfusion ratio results in hypoxemia. A decrease in admitted ventilation and resulting carbon dioxide retention also may occur as the lung restriction worsens. Clinical manifestations include a rapid ventilatory rate, marked use of accessory muscles, a low-grade fever, dry or non-productive cough, and a hyperinflated chest. If bronchiolitis is caused by an inhalation injury, pulmonary edema occurs rapidly. Respiratory distress with severe hypoxia frequently develops within 24 to 72 hours. Infiltrates can be seen on chest x-rays. A decrease in that ventilation-perfusion ratio results in hypoxemia. Diagnosis is made by spirometry and bronchoscopy with biopsy. Bronchiolitis is treated with appropriate antibiotics, corticosteroids, immunosuppressive agents, and chest PT. Bronchiolitis obliterans organizing pneumonia, or BOOP, is a complication of the bronchiolitis obliterans, in which the alveoli and the bronchioles become filled with plugs of connective tissue. Your bronchiolitis obliterans syndrome, or BOS, is an inflammatory fibrotic process that occurs as a complication of lung transplantation. It is associated with persistent loss of lung allograft function 3 or more months following transplantation and has a high morbidity. Diagnosis is made via spirometry and a bronchoscopy with biopsy. Treatment includes corticosteroids and other immunomodulatory agents. Pulmonary fibrosis. Pulmonary fibrosis is an excessive amount of fibrous or connective tissue in the lung. Pulmonary fibrosis can be caused by formation of scar tissue after active pulmonary disease in association with a variety of autoimmune disorders or by inhalation of harmful substances, coal dust and asbestos. Chronic inflammation leads to fibrosis with alveolar epithelialization and myofibroblast proliferation. Fibrosis causes a marked loss of lung compliance. The lung becomes stiff and difficult to ventilate, and the diffusing capacity of the alveolar capillary membrane may decrease, causing hypoxemia. Diffuse pulmonary fibrosis has a poor prognosis. When no specific cause for the development of fibrosis is known, it is called idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is the most common idiopathic interstitial lung disorder. It is more common in men than in women and mostly occurs after the age of 60. The median survival is only 2 to 5 years after a diagnosis. Idiopathic pulmonary fibrosis is characterized by the chronic inflammation, and recent studies suggest that it results from multiple injuries at different lung sites, with aberrant alveolar wound healing, which probably occurs in response to the complex interactions of environmental insults and genetic, epigenetic, and metabolic factors. Alveolar collapse, any fibroproliferative response, results in thickening of the alveolar capillary membrane, causing a decreased oxygen diffusion and hypoxemia. Progression of the disease results in decreased lung compliance, causing increased work of breathing, decreased tidal volume, and resultant hypoventilation with hypercapnia. Acute exacerbations of IPF can occur with rapid decompensation and a death rate as high as 50%. The primary symptom of IPF is increasing dyspnea on exertion. Examination shows diffuse inspiratory crackles, and diagnosis is confirmed by pulmonary function test, high-resolution CAT scan, and lung biopsy. Treatment includes oxygen corticosteroids and cytotoxic drugs, although success rates are low and toxicities are high. Additional therapies may include an antifibrotic drugs, inhaled interferon, and anticoagulant therapy. Some individuals may benefit from a lung transplant. Your environmental lung disorders, your exposure to toxic gases. Inhalation of gaseous irritants can cause significant lung injury and respiratory dysfunction. Commonly encountered toxic gases include ammonia, hydrogen chloride, sulfur dioxide, chlorine, phosgene, and nitrogen dioxide. Inhalation injuries and burns can include toxic gases such as carbon monoxide, cyanide, and ammonia from household or industrial combustants, heat, and smoke particles. Inhaled toxic particles can cause damage to the airway epithelium, cilia, and alveoli. There is an increased secretion of mucus, promotion of inflammation, and development of mucosal and pulmonary edema with airway obstruction. Surfactant and other protective buffers and antioxidants are inactivated. The cellular effects of toxic gases and polluted air are described in Chapter 2. Acute toxic inhalation is frequently complicated by the development of bronchoconstriction, airway obstruction with fibrous mucus, microcirculatory coagulopathy, and impaired gas exchange. Initial symptoms include burning of the eyes, nose, and throat, coughing, chest tightness, and dyspnea. Hypoxemia is common. Secondary injury because of the resuscitation, mechanical ventilation, and infection can occur. Treatment include supplemental oxygen, high-frequency percussive ventilation, lung protective ventilation when possible, inhaled anticoagulants, bronchodilators, and support of a cardiovascular system. Inhaled beta agonists may help relieve bronchoconstriction. Most individuals respond quickly to therapy. Some, however, may improve initially and then deteriorate as a result of the bronchiectasis or bronchiolitis. Prolonged exposure to high concentration of supplemental oxygen at normal atmospheric pressure can result in a relatively rare iatrogenic condition known as oxygen toxicity. The basic underlying mechanism of injury is a severe inflammatory response, mediated primarily by oxygen-free radicals. The result is cellular necrosis, or apoptosis with diffuse damage to alveolar capillary membranes, disruption of surfactant production, development of interstitial and alveolar edema, and a decrease in compliance. Treatment involves ventilatory support and reduction of inspired oxygen concentration to less than 60% as soon as tolerated. Pneumoconiosis represents a change in the lung caused by inhalation of inorganic dust particles, usually occurring in the workplace. As in all cases of environmentally acquired lung disease, the individual's history of exposure is important in determining the diagnosis. Pneumoconiosis often occurs after years of exposure to the offending dust, with progressive fibrosis of lung tissue and increased risk of lung cancer. The dust of silica, asbestos, and coal are the most common causes of pneumoconiosis. Others include talc, fiberglass, clays, mica, slate, cement, and metals, cadmium, beryllium, tungsten, cobalt, aluminum, iron, indium, and titanium dioxide nanoparticles. Deposition of these materials in the lungs causes a release of a pro-inflammatory cytokine. This leads to chronic inflammation with scarring of the alveolar capillary membrane, resulting in pulmonary fibrosis and progressive pulmonary deterioration. Clinical manifestations of advancement of disease may include a cough, sputum production, dyspnea, decreased lung volume, and hypoxemia. In most cases, diagnosis is made by performing a chest X-ray, CAT scan, or obtaining a careful occupational history. Treatment is usually symptomatic and palliative and focuses on the prevention of further exposure and promoting dust-free working conditions, along with pulmonary rehabilitation and management of associated hypoxemia and bronchospasm. Silicosis is a type of pneumoconiosis resulting from the inhalation of free silica, silicon dioxide, and silica-containing compounds, which occur in mining and in other industries involved with the extraction and processing of ores, the preparation and use of sand, and the manufacture of pipe, building, and roofing materials. Silica exposure activates innate and adaptive immune mechanisms and triggers inflammation with subsequent fibrosis. Acute inflammation contributes to the bronchospasm and wheezing, release of proteolytic enzymes, and toxic oxygen free radicals increases the risk for lung cancer. Exposed individuals may remain asymptomatic long after the nodules are visible on chest radiography. When clinical manifestations do appear, they include cough and dyspnea. There is no curative treatment for the disease, although corticosteroids may produce some improvements in the early, more acute stages. Screenings for lung cancer should be included for the management plan. Coal worker pneumoconiosis, or coal mine lung disease, or anthracosis, is caused by coal dust deposits in the lung. Although coal dust itself is relatively well tolerated by the lung, it is frequently inhaled as a mixture of coal, silica, and quartz, which is strongly inflammatory and involves the small airways. Its mild form is asymptomatic, except for possible chronic bronchitis. Its advanced form manifests as severe pulmonary fibrosis. Individuals usually are seen with a productive cough and wheezing. Symptoms are more severe with advanced disease and mimic those of chronic bronchitis and emphysema. Diagnosis is made by obtaining a history of exposure and observing chest radiographs for characteristic signs. There's no specific treatment for coal worker pneumoconiosis. Individuals with a mild form of the disease usually have a favorable prognosis. Those with more complicated forms often develop marked cardiopulmonary dysfunction. Asbestos exposure affects not only factory workers, but also individuals who live in areas of asbestos emission. Asbestos exposure can result in a type of pulmonary fibrosis called asbestosis, but can also cause lung cancer, mesothelioma, or pleural plaques, especially in those also exposed to cigarette smoking. Asbestosis is caused by the inhalation of hydrous silicates of various metals in fibrous form. Asbestos fibers cause inflammation and alveolitis. Activated macrophages release toxic oxygen-free radicals and cause cellular apoptosis, leading to both fibrosis and malignancy. The most prominent clinical manifestation of asbestosis with fibrosis are dyspnea on exertion, a non-productive cough, diffuse inspiratory crackles on examination, hypoxemia, and decreased lung volume. Progressive disease may take years and lead to respiratory failure and cardiac complications. Diagnosis is made by pulmonary function testing and a low-dose CAT scan. Therapy is usually supportive. Your hypersensitivity pneumonitis, also known as extrinsic allergic alveolitis, is an allergy, inflammatory disease of the lungs caused by repeated inhalation of organic particles or fumes. Many allergens, the antigens, can cause this disorder, including bacteria, fungi, and yeast. Your moldy or contaminated hay, your grain, your compost, cork, or wood dust. Your mycobacteria, your contaminated mists from standing waters, showers, and hot tubs. Animal proteins, your bird droppings or feathers. Animal pelts. And chemicals, your fumes from paints, resins, and glues. A genetic predisposition may increase the risk for this disease. An autoimmune type 3 hypersensitivity response is initiated by the alveolar macrophages and results in immunoglobulin G, your IgG, antibody production. Continued exposure results in a cellular immune type 4 hypersensitivity response. The immune and inflammatory response cause pneumonitis. Granuloma formation is common. Lung capacity and alveolar capillary diffusion are reduced. Allergic alveolitis can be acute, subacute, or chronic. The acute form causes a flu-like symptom, such as fever, cough, dyspnea, and chills, a few hours after exposure that resolve without treatment in 1 to 3 days. With continued exposure, the disease becomes chronic and pulmonary fibrosis develops. Your chronic allergic alveolitis causes cough, fever, fatigue, and weight loss, and gradually progressive respiratory failure. Diagnosis is made by obtaining a history of allergen exposure and by performing serum testing for precipitating IgG antibodies. The inhalation challenge, chest x-ray, high-resolution CT, bronchoscopy with a bronchoalveolar lavage, and in rare cases a lung biopsy. A treatment consists of avoidance of the offending agent, stopping smoking, and corticosteroid administration. Your systemic disorders of the lungs. Several systemic diseases affect the airway, pleura, or lung parenchyma, causing fibrosis, vasculitis, pulmonary hemorrhage, or granuloma formation. Clinical manifestations of lung involvement are usually nonspecific, and the diagnosis is based on involvement of other organs. There is usually no specific treatment, although corticosteroids often are used. Some of the systemic diseases affecting the lung are granulomatous disorders, such as your sarcoidosis, your Wegener granulomatosis, lymphomatoid granulomatosis, and eosinophilic granuloma. Connective tissue disease, such as rheumatoid arthritis, systemic lupus erythematosus, scleroderma, polymyositis, or dermatomyositis, Sjögren's syndrome, and polyarteritis nodosa, angioimmunoblastic or immunoblastic lymphadenopathy, cystic fibrosis, and Goodpasture syndrome. Whew, a lot. Your pulmonary edema is excess water in the lung. Normal lung contains very little fluid and is kept dry by the lymphatic drainage and balance among capillary hydrostatic pressure. Your capillary oncotic pressure and capillary permeability. In addition, surfactant lining the alveoli repels water, keeping fluid from entering the alveoli. Common predisposing factors for pulmonary edema include a left-sided heart disease, including or causing an increased pulmonary venous pressure, injury to pulmonary capillary endothelium, like that seen with an adult in respiratory distress syndrome, and inhalation of toxic gases and lymphatic obstruction. The pathogenesis of pulmonary edema is illustrated in figure 36.7. Other causes include a rapid pulmonary re-expansion after the upper airway obstruction and exposure to high altitudes. The most common cause of pulmonary edema is left-sided heart disease. When the left ventricle fails, filling pressures on the left side of the heart increase and cause a concomitant increase in pulmonary capillary hydrostatic pressure. When hydrostatic pressure exceeds oncotic pressure, fluid moves into the interstitium, or interstitial space. Fluid moves to the lymphatic vessels and is then removed from the lung. When the flow of fluid out of the capillaries exceeds the lymphatic system's ability to remove it, alveolar flooding and pulmonary edema develop. A pulmonary edema usually begins to develop at the pulmonary capillary wedge pressure, or left arterial pressure of 20. If the capillary oncotic pressure is decreased for some reason via anemia, nephrotic syndrome, or liver disease, pulmonary edema develops at a lower hydrostatic pressure. Your acute respiratory distress syndrome, or inhalation of toxic gases, causes injury to the alveolar capillary membrane. Capillary injury causes water and plasma proteins to leak out of the capillary and move into the interstitium. When plasma proteins move into the lung interstitium, they increase the interstitial oncotic pressure, which is usually very low. As the interstitial oncotic pressure begins to equal capillary oncotic pressure, water moves out of the capillaries and into the lungs. Lymphatic drainage can be blocked by compression of the lymphatic vessels, caused by edema, tumors, or fibrotic tissue, or by the increase in the systemic venous pressure that elevates the hydrostatic pressure of the pulmonary veins, into which the pulmonary lymphatic system drains. Your post-obstructive pulmonary edema, the POPE, negative pressure pulmonary edema, and your re-expansion pulmonary edema is a rare life-threatening complication that can occur after relief of upper airway obstruction, your post-extubation laryngospasm, after anesthesia, epiglottitis, laryngeal tumor, or obstructive tonsils. Attempted inspiration against an occluded airway creates excessive intrathoracic negative pressure, causing increased venous return and blood flow to the right side of the heart, and a decreased outflow from the left side of the heart from this increased afterload. This combination of events causes an increased pulmonary blood volume and venous pressure and leads to pulmonary edema. Your high altitude pulmonary edema, your HAPE, can occur after arrival at altitudes usually more than 8,000 to 10,000 feet and are related to the hypobaric hypoxic environment. The pathophysiology is not clearly known, but the hypoxic pulmonary vasoconstriction and increased pulmonary capillary permeability from increased pulmonary artery pressure are the proposed mechanisms. The mechanisms are non-cardiogenic and non-inflammatory. Treatment includes moving to lower altitude and oxygen therapy. Drugs may be used for prevention. Your clinical manifestation of pulmonary edema include dyspnea, hypoxemia, and an increased work of breathing. Physical exam may reveal inspiratory crackles, dullness to the percussion over the lung basis, and evidence of ventricular dilation, an S3 gallop, and cardiomegaly. In severe edema, pink and frothy sputum is expectorated, hypoxemia worsens, and hypoventilation with hypercapnia may develop. The treatment of pulmonary edema depends on its cause. If the edema is caused by an increased hydrostatic pressure resulting from the heart failure, therapy is geared towards improving cardiac output and volume status with diuretics, vasodilators, and drugs that improve the contraction of the heart muscle. If edema is the result of an increased capillary permeability resulting from injury, the treatment is focused on removing the offending agent and providing supportive therapy to maintain adequate oxygenation, ventilation, and circulation. POPE is treated with a positive end pressure ventilation. HAPE can be prevented by slow ascents, medications, and a descent to a lower altitude when symptoms occur. Individuals with any type of pulmonary edema require supplemental oxygen. Mechanical ventilation may be needed if edema significantly impairs the ventilation and oxygenation. And that, my friends, concludes this chapter for us. We'll jump into the next chapter here quickly, and I'll see you then.